So we're now going to demonstrate the side-to-side hand-sewn anastomosis. This is an isoperistaltic anastomosis, so the bowel is coming in this direction, comes to a blind end here. This is one of the resection margins. This is the other resection margin, so you've got another blind end. So you then lay the bowel alongside, so it's in the same direction, so it's isoperistaltic. So the contents will be coming down through the anastomosis and continue. This is a two-layered anastomosis. I've pre-marked the suture lines for the simulation model just for the purpose of teaching, and I've pre-marked them using one of the suture packs, which is about right, an oval, which is the outer layer, and then a single line, which is the inner layer. We're going to use a double-ended 3/0 PDS for this, or an equivalent. So this is a monofilament, it's a round-bodied needle. The idea being that the needle splits the muscle fibers of the bowel wall, and then as the muscles pull through, the bowel wall then closes over the suture. And this is a 3/0, which I'd always use for anastomosis. And it's a monofilament, which is my preference. Some people use a braided suture. I like the monofilament because of the way that it sort of glides through the tissue. Instruments-wise, I'm using some atraumatic, so non-toothed atraumatic forceps. These are Makindos, so they can be used to grasp the bowel. I'm using a needle driver, which is a short needle driver. I've got some small clips, mosquitoes or something equivalent. So first of all, I'm going to do the outer layer. So once you've orientated your bowel, you get your suture. Remember never to put a clip or anything actually on the suture material itself. You put the clips when the needle driver is on the actual the metal, the swaged end of the needle. So first of all, we're going to take a point about in the midline. These two lines are going to come together. This is the outer layer, the back wall. So we're going to take a bite of tissue, and you want a muscular bite. So effectively, you want either a full thickness or at least some muscle in the bite. We'll bring that through, and then we're going to put it through the second loop at the same level. And once you've done that, we're going to pull the suture so it's about halfway through, because you've got both needles on, and then you do a knot at that point. So I just do 3 throws of the knot here. It's a monofilament, so if this is an end knot, you do 7 throws. However, it's not an end knot, it's part of a continuous suture, so 3 throws is appropriate. And then put one of the needles on a clip. Like I say, you put the clip so it's on the swaged end. I have the needle pointing in to protect it so it's not sticking, and then effectively keep that out of the way so it's under a little bit of tension. I would normally have an assistant following, or I haven't got one today. However, the material for the simulation model that I use has got a rubber in it which does hold the suture quite nicely. Okay, so we're going to basically progress along this back wall towards ourselves. When we get to the far extent of the back wall, we stop and lock the suture, and then we do the same with the other end of the same suture in the other direction. So, and what's important, when you're doing this back wall, you've got to make sure that you stay parallel to the mesentery. So you don't want to migrate, for example, when we're coming this way, you don't want to migrate up the way. The reason for that is that we're going to do this layer, then another layer, then another layer, then another layer, which forms the outer layer of the back wall. That's the inner layer of the back wall, the inner layer of the front wall, and the inner layer of the outer layer of the front wall. So if you migrate up the bowel away from the mesentery, you end up running out of space. So just try and be aware and make sure that you continue in a straight line. And again, we're taking muscular bites. You can come out in the middle. Just make sure you don't get into a tangle, which is more easy to do when you've no assistant. And then go in the other side. And then pull it. And again, with your assistant, they'll keep this under tension. The simulation model should hold it. Equally, as well as coming out in the middle, you can, if it's lying in front of you, you can take a bite. And then if you know where you're going and you've got a clear view, you can take the other side in a one. pulling through and snug it down. And you're going to keep doing that in a non-migratory straight line. So on the model you can follow the lines which are pre-drawn, or which you're pre-drawn on your own models, to make sure that you go in a straight line. But in real life, effectively, just be aware of where the mesentery is and try and stick to a line that's parallel with it. And normally I'd leave gaps of 2 to 3 millimeters between each bite. I'm trying to go in to the perpendicular to the muscle, so rather than taking tangential bites where you just get a bit of serosa, you just don't want to just strip the serosa. That's probably not a big enough bite, so I'm going to come out and do that again, and then stay in a straight line, pulling it snug. So we're nearly to one end. Just going to keep going a little bit further. So there's different types of atraumatic forceps. I generally use the McIndoes because that's the commonest forceps that we have on the set. We do have DeBakey's, which are a lovely forceps, again non-traumatic. The DeBakey's that we have for some reason tend to be longer. So, and sometimes if you're doing surface surgery, like this is effectively, the longer forceps are just a bit more cumbersome. Although I don't think cumbersome should be a word used for DeBakey's routinely. They're a lovely instrument. The McIndoes are a nice instrument too. Okay, so we're pretty much at the extent. I'm just going to do a couple more just to make it easier when we can come around the corner and do the front, the outer layer of the front wall. Now just creeping up the bell, I'm going to come out there. And again, if you do come out, just make sure you don't make a mistake and lock the stitch. Okay, I'm now going to lock at this point. So I've now, to lock it, I've come through the loop. I'll just do that again. Oh no, I'm making a mess of it. So if you imagine we've just done the stitch, then rather than we would just pull through at this point, to lock it, you just put the needle through the loop before you snug it down. And then as you pull that in theory locks it off. Okay, once you've done that, you get another mosquito or equivalent clip, and then you hand that to one side. And you go to your other end and you're going to do exactly the same in the other direction. That was just a bit far away. I'm going to do another one in the middle there, just to get that nicer. Whoopsie daisy, sorry about the noise. Okay. And again, following both lines on the model so we don't migrate. It looks a little bit messy that, but you get the idea. We're effectively just going in a straight line, not too far apart, and following the lines so we're not migrating away from the mesentery too far. What I normally do is, I'm doing this with an assistant, is with someone who's familiar, who's done the procedure before. I do half and they do half, because we'd normally be on either side of the patient, so one of us would be standing on this side and one on this side. And you can stitch towards yourself and then get your colleague to stitch towards themselves. It's good to share operating. Okay, so we're just coming around the corner again. I'm going to come out and just turn. Oops. It's a word you don't want to hear from a surgeon. Whoops, I'm just knocking the camera stand. Okay, and let's snug that down. I'm going to do one more and then lock it exactly the same as I did with the other side. There's one more at that level. The model does work quite well wet as well. In fact, it's probably a little bit better wet because it's more realistic. It's sort of a bit slippery, a bit more like bowel, so it's quite good wet. Okay, so that's the outer layer back wall. So I'm going to put this one on a clip. My other one is on a clip. Okay, so that's outer layer back wall. So the next stage of the procedure, we're going to make the enterotomy. And the beauty of doing a side-to-side anastomosis is that you can make the enterotomies exactly the same size, so there's no size discrepancy. I'd normally just use a handheld diathermy just on coag. It's quite a vascular structure, so if you cut through the bowel wall, you'll get quite a lot of bleeding, or what appears to be a lot of bleeding. It's not a major drama, but it just makes the operative feel a bit messy. I just use a coag handheld diathermy. I'm just going to use a scalpel to make the enterotomy on one side and on the other. There's a pair of scissors. So we're just making the enterotomy. Again, I just use, normally to do this, I have myself and my colleague have some atraumatic forceps, and I'll just simulate what I do. These are traumatic, so ignore the teeth, but I'd have my colleague or me holding one side, a colleague the other, and then just use the diathermy in between, and then you can gradually walk along, just to do it in a nice controlled fashion. I'm just using some heavy scissors. Okay, so that's about right. And you've just got to match the enterotomies. The only thing I will say, if you're doing a side-to-side ileocolic anastomosis, for example, after a right hemi, often it's worthwhile making the colonic enterotomy a bit shorter, because the colon, because it's wider, it tends to stretch more. So if you make them identical lengths in a linear fashion, the actual defect ends up stretching and being bigger on the colonic side, so you end up with a discrepancy which you have to correct for. So, okay, that looks about right. So I'm now going to get a second suture, exactly the same suture. So this time we're effectively going to close this leaf to this leaf, so we want these together. So this is the back wall inner layer. So you start on the inside, you're taking full thickness. You don't need to exclude the mucosa because this is going to be buried. It's already buried by this outer layer. And you're taking full thickness, nice big bites, making sure you get muscle. So again, you do a middle stitch, pull the stitch so there's half either side, and then do a knot with 3 throws. Exactly the same. So the suture, when you do the knots, the suture tends to lie sort of in the way it wants to lie. So there's one naturally pointing in one direction and one end naturally pointing in the other direction. So I'll use this one in this direction and this one in this direction. So again, once you've got that, I'm going to use another clip. I'm just going to hang that in one direction. So it's quite echoey in here. Okay, and then again with your colleague following you, or not if you're friendless like me today, you're just going to do exactly the same. So we're going out in the middle, full thickness, pull it through. And these I normally do 2 to 3 millimeters apart. I may end up doing slightly bigger gaps today just for the purpose of the simulation for speed. big bites, all the layers, mucosa, muscle, serosa. And we're going to go all the way until we get to the apex, and then we're going to do our special turning the corner stitch. Which is called a canal stitch, which you will probably have heard of. If you haven't, don't worry, but it's a nice stitch. You can look it up on Wikipedia or Google or what have you. So we're going to keep going. We're going, as you can see, we're going in to out, out to in, just over and over effectively. And I'm going to do one more of them, and then we're going to start the canal, and I'll talk through the canal a bit slower. So the canal stitch is a way of turning the corner. Effectively, we've got a 180-degree bend to get round here, because we're going here and I'm going to come back on ourselves. So it's difficult to do that with a stitch we've just done. It just becomes quite distorted. So instead, when you get to the point where you want to start turning the corner, you stop when you're on the inside, and rather than going over to the other side again, as we would have if we were continuing in the same manner, we're going to come out of the same loop of bowl. So I'm turning my needle round, and I'm on the inside here. So I'm going to come from in to out, just alongside it. It's important when you do this, don't come in to out over here somewhere, because you leave a big gap. You almost go back on yourself. Just make sure you're coming back out quite close to where you went in, and then pull that through. Okay, and then get your colleague to start following you again. And what you're going to do, we're going to go over to the other loop of bowl now. We're going to go out to in, and then we're going to turn around and come from in to out on the same limb. And again, what you want to do is just make a little bit of progress in the direction that you're going around the corner. So you don't want it right, you don't want either here or on the other side of it, you want it this side a little bit. So I'm going to come out about there. So we've made a bit of progress. Okay, and then we come back over to the other limb and we do the same again. So out to in, turn the needle, in to out, making a bit of progress. Over to the other limb, out to in, we're right at the apex now. In to out, pull it through. Across the road again, at the apex here, out to in, turn around without knocking the camera, in to out, and then once you've got round effectively, we can see we're now on the front wall, the inner layer of the front wall. You can then just start doing the stitch as you were before, out to in and in to out. So you can revert back to how you were previously doing. So out to in, and then again make sure you don't leave a gap, in to out. So you can see we've successfully turned the corner there. And pull it snug. Okay, now at this point, once you've turned the corner, you've done your first normal stitch, stop at that point. So you want to go and do the other side. So put that needle that you've just finished with on a clip and put it somewhere safe. And then this is our stitch for the inner layer. I'm going to do exactly the same, heading the other direction. And again, this is something you'd hand over to your colleague, so you do one direction and get your colleague to do the other. Full thickness, mucoso-muscular serous. Don't know if that's a word. Okay. And the model is a little bit elastic, so it can get in the way and occlude vision a bit. When it's wetted, it's a little bit more floppy, like normal bowel. Okay, and we'll just keep going. And again, just making sure you don't leave big gaps and making sure you don't lock the stitch by accident. And then again, we're going to get towards the end and we're going to do a canal. So I'm going to come out there and just turn. I felt like I was going obliquely and going to make too big a gap. And pulling that out. Again, come out in the middle, go back in, did I lock that? I might have locked that, not to worry. That's what happens when you haven't got a friend to follow. Okay. It looks okay, so we're going to do one more here and then we're going to do one more in the normal way and then we're going to start canelling. So we're in the inside there. I'll pull that through. Okay, and then rather than crossing over, we're going to stay on the same side, we're going to come out to the same side. But again, not too far round. So now on the outside, then we cross over to the other loop and we go from out to in, turn the needle and in to out, just making a little bit of progress, getting towards the apex. Again, I'm just making sure I'm not locking it again. And then we cross over. So people talk about going into a pub from out to in, so we've gone into the pub, have a drink, and then come from in to out, so come back out of the pub, and then you cross the road and go into another pub or cafe or whatever. Have another drink, come back out, cross the road and go back in. Just a way of remembering, you almost talk it to yourself as you're doing it so you don't get confused, because it's a simple thing but it is easy to get confused with them. And like I say, each time you're doing one of these stitches, you just make a little bit of progress in the right direction. So we're pretty much all the way around now. So now we've just got the front wall inner layer. So I'm just going to keep going to about the middle. So we're now on the outside here. So rather than, I'm going to cross over, but rather than going out to in to out, I'm just going to go on the same side. I'm going to go out to in to out on opposite sides. So back to the way we were doing it. And again, I'm just being careful not to lock there. So we're now doing the front wall inner layer. And the further you get round, the easier it gets. And also, if you do get bleeding from the cut edge of the bowel, it tends to be a bit messy to start with, but the further round you get, it becomes less and less, and the anastomosis looks neater and neater. And just make sure we don't catch the back wall. So out to in to out. So making good progress now, and you can use your forceps to guide the stitch down. Same detail, out to in to out. Okay, we're gonna snug that down. You can get your colleague to, or you can just keep that under a bit of tension and swap over onto this other one and do the same, so we meet in the middle. So now going out here, we're going to go over the road in one side and out the other. It's just a normal over and over stitch. And again, you just use your forceps to guide it down so you don't leave any gaps. So each time we do it, we're seeing the stitch in the middle and bringing it through. As you get closer and closer to finishing, the gap becomes smaller and smaller, till at the end you can just go through and through, as long as you're happy that it's safe and you're not catching the back wall. You know, you don't take a great big bite and catch something deep in there. If it's like this and you know you've got plenty of space, you can go through and through like that. Again, and that's what I mean about using the forceps. If I pull it tight just now, it'll end up down there, whereas what I want to do is make sure it lies like that. So you just use your forceps to assist you. Through and through. And same again. Okay, now I have, because I'm doing it myself and not my assistant, I'm doing it from the same direction. Both ends have ended up on the same side of the barrel. You could just tie them there, but it makes a bit more sense to tie across. So I'm just going to go through. That makes a bit more sense to me anyway. Go through, so I've got this one on the other side. So now I've got that snug, this one snug, and we can just tie these two together. So I'm going to cut the needles off. Tie, so that is effectively, the anastomosis is intact now and should be airtight, because this is an end suture and it's, or the end of the suture line, and because it's a monofilament, you do at least 7 throws here. I don't know how many that is, to be honest, but I think that's 7 or more. Okay, and cut it not too short but not too long. Okay, we're then left with the front wall to do. Now at this point, normally what I'll do is test the anastomosis. We know that the lumen is just through this suture line, so what I normally do is get a needle and syringe at this point, or just a syringe. I normally use a little blue needle, fill the syringe with air, so a 20mm syringe, poke the needle right through the suture line, avoiding the sutures, and then inflate. And if you and your colleague occlude both lumens like that, as you inflate, the anastomosis blows up like a balloon, becomes airtight, and you can test that it's airtight. Because if you've got a pink anastomosis, if both limbs are pink and there are no other risk factors for the failure of the anastomosis, and you inflate it and it's airtight, you pretty much ticked every box, and there's nothing more you can do to prevent that from leaking. So that should be a secure anastomosis. When you blow it up with gas or with air, if it bubbles and gives way, then you can put an extra stitch in at that point. So it's a nice little test. So we'll assume we've tested it, it's airtight. So we're now going to take one of our stitches, and we're just going to complete the anastomosis by completing the outer wall. And all you do here, we've sort of got round there, we're on we've got a lock stitch, so I'm just going to take a bite of both walls beyond, like so. Pull that through. Okay. And then we're just going to follow this line again. And it might be a little bit wide, but I'll follow it because I've drawn it. But you get the idea. Effectively, we're wanting to envelope the inner layer with another layer of bowel. And this is the point where if you started migrating, or you started too far around the bowel to start with, you end up running out of space and you're encroaching on the opposite wall, or the opposite mesentery, sorry. So if you do this stitch too close to the inner layer, it's difficult to bury it. So you actually need these little flaps of tissue. If you go too far apart, then you're closing it under tension. So it needs to be just right. And what I normally do is just to one side, keep doing this layer with one stitch from one direction, just to either just before or just after the knot. You just don't want to tie the next knot on top of the last knot, if that makes sense. You don't want the outer layer knot to be directly over the inner layer knot, inner wall knot. So I'm just going to keep going just beyond that knot. Sometimes you'll have a discrepancy. You might have tied it not quite in the middle and one length of suture, or one end of the suture will be longer than the other, in which case make a judgment as if you've got the longer end, go beyond the knot. If you've got the shorter end, go just before the knot. Does that make sense? Am I waffling? So we're going to just beyond the knot. Okay, I'll leave that to one side. Get my other. I'm going to do the same, so we're just getting a bit of wool. On both sides. I'm going to come round towards the middle. Again, decent bites, don't go crazy, but you want to get at least a bit of muscle in these bites so they've got some substance. Catching my enterotomy line. Going back to Canal, so Canal he was a surgeon, and the canal suture is named after him. From what I understand, his wife was a seamstress, and he went home one night and explained how he had difficulty doing this 180-degree turn, and she went, "Honestly, that's simple, why don't you just do this?" And he went, "Uh-huh," and then promptly named the technique after himself and took the credit for it. I might be being unfair, but that's what I understand happened, or something like that. Okay, so we're nearing the end now. So I've got that, I got that. I'm going to just do one, I've just got a slight discrepancy there, so I'm going to put one straight through the middle there, and through that. Pull that snug. I'm going to cut my needle off. Pull both snug. And then tie that. And again, 7 throws. 4, 5, 6, 7. Nice and snug. And there we have it. So that's the Isoperistaltic 2-layered anastomosis using a continuous 3/0 PDS suture. You can check the lumen by feeling through, you can feel the way through, and it's a decent, nice wide anastomosis. You can, like I say, you can match the lumen size, so there's no size discrepancy, and in conditions such as Crohn's disease and things like that, where you anticipate potential recurrent problems and stricturing, you can make a nice wide anastomosis. You can increase the size of it to prevent problems in the future related to recurrent disease and stricturing at the anastomosis. And the anastomosis is a common place for Crohn's disease to occur, which is why it's worth thinking about. Okay, I hope that all makes sense. Thank you.